Welcome to my channel! Welcome to Nurse Next Door. I'm your friendly neighborhood student nurse, Erien. And today, we will be talking about a lot of nurse things. So I hope you stay tuned and listen to our lectures. Today's topic would be about benign neoplasm. Aren't you curious what is benign neoplasm all about? If you're ready, let's go! So what is benign neoplasm? The definition of benign neoplasm is that these are non-cancerous forms of tissue growth. A benign neoplasm is a growth that does not have cellular features of cancer or precancer and is thus highly unlikely to become dangerous. It looks a lot like the tissue with the normal cells from which it originated, and it has a slow growth rate. Benign neoplasms do not invade the surrounding tissues and they do not metastasize. Thus, characteristics include slow growth, resemblance to tissue origin, circumscription, lack of invasion, absence of metastasis. Benign neoplasms usually arise in a solitary manner, but may be multiple. When we say benign, it means non-cancerous, and neoplasm means excessive tissue growth. Tissue growth. Oh, but we're not talking about this tissue growth. Here's what it looks like. Benign neoplasm can arise at different parts of the body. But today, we're talking about the benign neoplasm that arise in the female reproductive system. And there are different types of benign neoplasm in the reproductive system. First one is polyps. One of the common types of benign neoplasm is the polyps. What is polyps? Polyps is one of the more common benign neoplasms. These are benign growths that frequently result from infection, and they are most commonly to appear on the cervix and in the uterus. Cervical polyps tend to be grayish-white, and they appear after menstruation, while endocervical polyps tend to be cherry red, and they are more likely to appear on multiparous women aged 40 to 60. And they typically appear on perimenopausal and menopausal women. Last is the endometrial polyps. These polyps are rare for women ages less than 20 years old, while the incidence increase at the peak age of 50, and they tend to decline after menstruation. Most polyps are asymptomatic, but mild symptoms might occur, including vaginal bleeding and discharge. The therapeutic management for this benign neoplasm is removal via forceps during hysteroscopy or DNC and laser vaporization. Another type of benign neoplasm that may occur in the female reproductive system are called uterine leiomyomas or fibroids, or simply myomas. Fibroids or myomas are benign growths that usually present and tend to grow rapidly during the childbearing years due to estrogen dependency and stimulation. This begins as a simple proliferation of the smooth muscles, and they tend to shrink upon menopause. The risk of fibroids is usually highest at around the age of 45, and it may appear in different locations of the uterus. First is intramural. It is within the uterine wall surrounded by myometrium, submucosal or under the endometrium or endometrium cavity, subserosal, the outer surface of the uterus or under the serosa, and wandering or parasitic. These myomas are pedunculated. It twists on its peduncle, and when it breaks and attaches to other tissues are called omentum. Intraligamentary, myomas appear in the pelvic ligaments, and lastly, cervical, the myomas obstruct the cervical canal. Therapeutic management for this benign neoplasm are as follows. For medical, the woman may be prescribed by a gonadotropin-releasing hormone agonists, progestin antagonist, and uterine artery embolization. And for surgical, Myectomy is possible, laser surgery, and hysterectomy in the abdominal, vaginal, or laparoscopic. Hormonal methods of treatment have advantages and disadvantages. The advantage for hormonal methods is that this is non-invasive, reduces the size, and symptoms often improve. While the disadvantage, it has serious side effects for long-term use and may regrow if medications have stopped. The following is the table for the treatment options for myomas or fibroids. Third type of benign neoplasm in the female reproductive system is the ovarian cysts. These ovarian cysts are fluid-filled sacs in the ovary. They are common and usually form during ovulation. These are common especially in women who are pregnant or haven't gone through menopause yet. There are also different types of ovarian cysts, which includes follicular cyst, corpus luteum cyst, fatal luteum cyst, and polycystic ovarian syndrome or PCOS. These ovarian cysts can be treated and must be diagnosed as either benign or malignant. To determine whether benign or malignant, a transvaginal ultrasound or laparoscopy is usually used. Oftentimes, ovarian cysts can be controlled with oral contraceptives and pain relievers. Polycystic ovarian syndrome or PCOS drugs and non-drug therapy and lifestyle changes are also effective for therapeutic management. And last but not the least are Bartholin cysts. These Bartholin cysts are benign neoplasms that blocks one of the ducts of the Bartholin glands that may lead to possible infection and abscess development. The therapeutic management for this is conservative methods of surgery. The nursing management for this disease includes nursing assessment. Assess for the client's health history, signs and symptoms of disease, and infection. Usually, it is asymptomatic if the cysts are small. Assist the client in physical examination and search for protrusion of tender labial mass. The nursing management if the client is going to have surgery for preoperative care includes reduce pain, provide education, and explain the surgery effects on menstruation, menopause, sexual activity, and hormonal balance. While the post-operative care includes tell the patient to report the abnormal bleeding of pelvic pain immediately. Benign neoplasms also includes complications like dysfunctional breathing on the possibility of losing the reproductive system, risk for infection, and constipations. Make sure to inform the patient about these complications and educate them about ways on how to cope with these complications. I hope you learned something today about benign neoplasms, and stay tuned for another episode of Nurse Things together with me. Thank you! Hi! Welcome to another episode of Nurse Next Door. I'm still your host, your friendly neighborhood student nurse, Erien, and today we will be talking a lot about juvenile diabetes mellitus. What is it and how is it manifests and how we will take care of it, everything about juvenile diabetes mellitus. So I hope you stay tuned and listen. A lot of people know about diabetes mellitus, but what they do not know is that it has a different categories or types, and it can also occur not only to the elderly but also to children. And today we will be talking about that juvenile diabetes mellitus. So, what is really juvenile diabetes mellitus? Let's find out. The definition of juvenile diabetes mellitus is that this is a chronic disorder of metabolism characterized by a partial or complete deficiency of hormone insulin. Diabetes mellitus has been classified according to the type of treatment needed. The old categories were insulin-dependent diabetes mellitus or IDDM, or known today as type 1 diabetes, and the other is the non-insulin dependent diabetes mellitus or the type 2 diabetes. So here's some fun fact. So in 1997, the terms insulin-dependent diabetes mellitus or IDDM or non-insulin diabetes mellitus or NIDDM, these terms were eliminated because treatment can vary and some people with NIDDM require insulin. And because these terms do not indicate the underlying problem, the new terms are type 1, written in numerical form, and type 2 diabetes. Juvenile diabetes mellitus is also called as type 1 diabetes or insulin-dependent diabetes. So why do we call it juvenile? Juvenile because the onset of disease occurs at the age younger than 10 years to 19 years old, and most diabetes of this age group are type 1. So diabetes mellitus in children can occur at any age, but it has a peak incidence between ages 10 and 15 years old, with 75% diagnosed before 18 years of age. The incidence of diabetes mellitus is slightly higher in boys than in girls, with a ratio of 1:1 or 1.2:1. The odds are higher for African American and Hispanic children. According to statistics, nearly 50% of them will develop diabetes. I know many of you are wondering what really happens to a person with diabetes. Particularly, the type 1 diabetes is characterized by the destruction of the pancreatic B cells. These cells are produced by the pancreas, and these cells produces insulin. The destruction of these cells usually leads to absolute insulin deficiency. Type 1 diabetes has two forms. First is the immune-mediated diabetes mellitus, or the autoimmune destruction of the beta cells. This typically starts in children or young adults who are slim, but it can arise in adults of any age. The second form is the idiopathic type 1 diabetes, which refers to the rare forms of the disease that have no known cause. So, how would someone know that they have a diabetes mellitus? First, it would be manifested in the body. So what are the clinical manifestations? The clinical manifestations of type 1 diabetes mellitus or juvenile diabetes mellitus is that the 3 P's of diabetes, which is polydipsia, the excessive thirst, polyuria, the excessive urination, and polyphagia, the excessive hunger. Patient would also manifest fatigue, irritability, shortened attention span, lowered frustration tolerance. The patient would also experience dry skin, and which may also lead to poor wound healing. It's weight loss, blurred vision, headache, frequent infections, hyperglycemia or elevated blood glucose levels, and glycosuria. And then diabetic ketosis, which manifests by the ketones and glucose in the urine, and dehydration in some cases. And last is the diabetic ketoacidosis, which follows by dehydration, electrolyte imbalance, acidosis, deep rapid breathing, or called as cosmal respirations. You must be wondering, why weight loss? Why a patient with diabetes is losing weight when she or he has a lot of stored glucose in the body? That may be the case for type 2 diabetes, but with type 1 diabetes mellitus, when glucose concentration in the glomerular filtrate exceeds the renal threshold, glucose spills into the urine, which causes the glycosuria, along with the osmotic diversion of water or polyuria, or the excessive urination, which is a cardinal sign of diabetes. The urinary fluid losses causes the excessive thirst observed in diabetes. This water washout results in a depletion of other essential chemicals, essentially potassium. The body is actually in a state of starvation during insulin deficiency. So, without the use of carbohydrates for energy, fat and protein stores are depleted as the body attempts to meet its energy needs. The hunger mechanism is then triggered, but increased fluid intake or polyphagia enhances the process by further elevating the blood glucose. So simply stating, patient with diabetes experience polyuria. So with polyuria comes with also polydipsia because The excessive urination causes the body to lose excessive fluids, and it triggers the consumption of water for the person. And with insulin deficiency, the body has no stored carbohydrates. Thus, it triggers now the polyphagia, or excessive hunger. Let's remember the cardinal signs of diabetes mellitus: the polyuria, polydipsia, and polyphagia. Okay, so now let's discuss what is the medical management for this disease. First is the diagnostic evaluations. What belongs in the diagnostic evaluation? First is the findings of hyperglycemia, glycosuria, and ketosis are sufficient to indicate diabetes. Next is the glucose tolerance test, which may include the 8-hour fasting blood glucose level, random blood glucose, or oral glucose tolerance test, or also called as OGTT. Next is the urine test. Glycosuria by itself is not a diagnostic examination of diabetes, but with this can be a confirmatory test for diabetes. Go to treatment. After the diagnostic evaluation, let's go and discuss treatment. What are the treatments appropriate for type 1 diabetes? So the definitive treatment for juvenile diabetes mellitus or type 1 diabetes mellitus is called as the insulin therapy. This therapy replaces the insulin in the body. So insulin replacement is the cornerstone management of type 1 diabetes mellitus. Insulin dosage is tailored to each child based on the home glucose monitoring. The goal of this insulin therapy is to maintain the near normal blood glucose levels while avoiding too frequent episodes of hypoglycemia. Maintain near normal blood glucose levels of less than 126 mg per dl and glycosylated hemoglobin of 7% or less. The preparation for this insulin, the insulin is available in highly purified pork preparation and in biosynthesized human insulin. But most clinicians suggest human insulin as the treatment of choice. Insulin is available in rapid, intermediate, and long-acting preparations. And all are packaged in the strength of 100 units per ml. Next, let's discuss about the dosage of insulin. Conventional management has consisted of twice daily insulin regimen of a combination of rapid-acting and intermediate-acting insulin drawn up in the same syringe and injected before breakfast and before evening meal. This allows for sufficient time for absorption and results in significantly greater reduction in the postprandial rise in blood glucose. Next is administration. Daily insulin is administered subcutaneously by twice daily injections, by multiple dose injections, or by means of an insulin infusion pump. Next is monitoring. Daily monitoring of blood glucose levels is an essential aspect of appropriate diabetes mellitus management, or also called as the self-monitoring of blood glucose or SMBG. So how can you do this? So here are the step-by-step instruction in doing the self-monitoring of blood glucose. First, do the aseptic technique of washing your hands with soap and drying them well. Second, insert the test strip into the glucose meter. Third, insert the lancet into the lancing device. Then, prick the end of your finger on the side. Gently squeeze the end of the finger if necessary. 6. Apply the blood to the test strip. Wait for a few seconds and insert the test strip into the monitoring device. And then wait for a few seconds to know the results. Read and write down the result in a logbook or store it in a glucose meter. And lastly, of course, what is the role of the nurse in managing this disease? So the nursing management includes the assist the client with nutrition management and planning as part of treatment. So nutritional needs for children with diabetes are no different from those of healthy children. They need sufficient calories to balance daily expenditure for energy and to satisfy the requirement for growth and development. Meals and snack must be eaten according to peak insulin action, and the total number of calories and proportion of basic nutrients must be consistent day to day. Next is encourage exercise. Exercise is encouraged and never restricted unless indicated by other health conditions. Exercise lowers blood glucose levels depending on the intensity and the duration of the activity. The type and amount of exercise should be planned around the child's interests and capabilities. Third, explain to the child, if the child is in school age, and parents the nature of the disorder and the possible treatment regime. Fourth, monitor the vital signs during the acute phase, the input and output, blood and urine glucose, and watch out for signs of hypoglycemia and hyperglycemia, as this signs requires prompt reporting. Provide teaching. Teach the client about the avoidance of concentrated sweets or carbohydrates like jams, jellies, candies, honey, and desserts. Teach them also about the signs and symptoms of the disease, the causes, and the emergency management in case of hypo and hyperglycemia episodes. Of course, teach them also about the administration of insulin. Inform them about the basic injection techniques or use of an orange practice, the injection sites and rotation of site to be injected. It can be in the abdomen, hips, thighs, deltoid, upper arm, and make sure to tell them that the lower arm is not a good site. Next, have a return demonstration of all the parties involved, which is the child and the parents. So, the nurse should supervise the actual insulin preparation and injection. And of course, teach them about the aftercare of insulin and equipment. Nurse should also manage for preventing the infection, especially in the respiratory and skin infections. So, of course, offer a meticulous skincare, prompt treatment of bruises and cuts, and inform them about proper footwear, that it should be well fitted and no barefooting. The nurse should also promote safety of the patient. So, instruct the clients to always carry a diabetic information card, which includes the person to call in case of emergency. And lastly, provide psychological support. Encourage or allow the parents and child to express concerns and feelings about the disease. Provide reassurance, but avoid giving false reassurance. As diabetes mellitus is a chronic disease, there are also complications. So, here are the complications of this disease. The long-term complications of diabetes involve both the microvasculature and microvasculature. The principal microvascular complications are nephropathy, retinopathy, and neuropathy. Microvascular disease develops during the first 30 years of diabetes and beginning in the first 10 to 15 years after puberty, with renal involvement evidenced by proteinuria and clinically apparent retinopathy. Hypertension and atherosclerotic cardiovascular disease are also major causes of morbidity and mortality in patients with diabetes mellitus. Other complications have been observed with children with type 1 diabetes mellitus, which includes the hyperglycemia, which appears to influence the thyroid function. This also limits the mobility of small joints of the hands and feet. So, I hope you learned something about our topics for today. So, stay tuned for another episode in The Nurse Next Door. Again, I am your friendly neighborhood student nurse, Erien. And bye! See you next time!